I'm Dr. Moinak Banerjee, consultant endocrinologist in R.N. Hospital, Kolkata. So today I'm going to discuss about the metabolic and glycemic outcomes of empagliflozin and linagliptin combination. So we all know that type 2 diabetes is a common metabolic disease, and there are various pathophysiological mechanisms that lead to development of type 2 diabetes. And empagliflozin linagliptin is an once daily sodium glucose cotransporter type 2 inhibitor, the SGLT2 inhibitor, and DPP4 inhibitor fixed dose combination product that we have with us as an adjunct to type 2 diet and exercise in adults with type 2 diabetes. And now coming to the glycemic outcomes and their mechanism of action, we know that the empagliflozin and linagliptin have complementary mechanisms of action. And empagliflozin basically inhibits the SGLT2, and it is a predominant transporter, and that is involved in 90% of glucose reabsorption from the glomerular filtrate back into the circulation. And thus, with blockade of SGLT2, it increases the urinary glucose excretion, which lowers the blood glucose levels. Whereas linagliptin inhibits the DPP4, and that enzyme rapidly degrades the incretins. What are those incretins? Incretins are GIP and GLP-1, and those incretins stimulate the insulin release and decreases the circulating glucagon in a glucose-dependent manner. So when I say that glucose-dependent manner, that means their mechanism of action basically depends on the circulating blood glucose levels. So that's exactly why they are associated with minimal risk of hypoglycemia, just like SGLT2 inhibitors, which direct mechanism of action is the amelioration of the glucotoxicity. Now, both of these agents have minimal hypoglycemia risks, and they can have also a potent glucose lowering actions. So apart from these glycemic outcomes, there are various metabolic outcomes which can be addressed by the SGLT2 inhibitors. So they produced a modest weight loss, and 3 to 4 kilogram of weight loss has been noted in the various RCTs on SGLT2 inhibitors. And they have also effects on visceral fat and total fat content of type 2 diabetes individuals. They can act on uric acid excretion. They increases the uric acid excretion basically because of the fact that the excess glucose gets exchanged by uric acid in GLUT9 that is present in the distal renal tubules. And they also have indirect anti-inflammatory effects. There may be macrophage polarization in the adipose tissues. There may be browning of the adipose tissues and upregulation of the uncoupling protein 1, which leads to the loss of energy storage. And all these factors overall lead to reduced insulin resistance and a favorable impact on lipid profile as well. Now, coming to the benefits beyond glucose control, we all know that SGLT2 inhibitors also activate tubuloglomerular feedback and via natriuresis, and they protect kidneys from hyperfiltration injury. And a meta-analysis of RCTs have also indeed shown that empagliflozin can reduce the heart count outcomes of end-stage kidney disease or renal replacement therapy initiation. And that's why they can be an excellent choice for patients with CKD for improving the glycemic control if the eGFR is 30 to 60. Even the guidelines suggest that we can continue SGLT2 inhibitors even if the eGFR falls below 30 until dialysis is initiated. But the problem is that their glucose lowering benefits are not there in advanced stages of CKD. Now, to complement this effect, we all know that linagliptin can also be used in advanced stages of CKD, and linagliptin actually can improve glycemic outcomes regardless of the eGFR, even in the advanced stage of CKD. So in advanced stage of CKD, this combination is an excellent choice for patients with type 2 diabetes, because SGLT2 inhibitor, despite their no actions on glucose lowering, they have an impact on heart, lowering the heart adverse renal outcomes, whereas linagliptin can improve the glycemic control even in advanced stage of CKD. Now, coming to other important factors, we all know that multiple cardiovascular outcome trials have shown that SGLT2 inhibitors have major cardiovascular benefits, which will be actually discussed in a detailed manner by Dr. Devdatta Majumdar. So I'm not going into the details of it. And we all know that SGLT2 inhibitors can also reduce fat content in liver. So in an indirect way, they can ameliorate the steatohepatitis if the patient has non-alcoholic fatty liver disease. So coming to the clinical applications from guidelines, what do guidelines say? If your patients have high risk atherosclerotic cardiovascular disease, heart failure, or chronic kidney disease at baseline. The guidelines clearly now have recommended that regardless of metformin use, you can consider SGLT2 inhibitors along with linagliptin also if you think that is needed for good glycemic control. And in fact, there are evidence to suggest that this combination actually mitigates the risk of genitomycotic infection or urinary tract infection, which is seen with SGLT2 inhibitor monotherapy, because of the fact that this combination offers quick glycemic control compared to the SGLT2 inhibitor monotherapy. That's why there is less risk of genital mycotic infection that is normally seen with. Another important factor is that if your patients do not have any of this, ASCVT, heart failure, or CKD at baseline, but glucose is not controlled on optimum doses of metformin or sulfonylurea, you must consider this combination. And even if you can consider it as second line, for particularly those patients who are obese and who are motivated to lose weight and who have non-alcoholic fatty liver disease at baseline, and also have at high risk of gout. So for those patients also, you can consider it as a second line to metformin. So this would be all from my side. And we all know that type 2 diabetes is also associated with high risk of cardiovascular disease. And even mere presence of type 2 diabetes is also considered as CVD risk equivalent. So, and there have been remarkable emerging evidence with regard to the cardiovascular benefits of SGLT2 inhibitor in past few years. And to take us through all that, we have with us Dr. Devdatta Majumdar, who is the consultant cardiologist in R&T Hospital. And over to you, sir.
So as I was saying, SGLTs wonderfully complement the mechanism of DPP4 that we've learned from Moinak, and we were already aware of that. But it is always good to learn once again these mechanisms, these basics of these two wonderfully, devised molecules, which finds a place in diabetic management. But we've also understand that since the year 2008, that glucose, the approach of diabetes management has changed from being entirely glucose centric to a holistic approach. We call it as a cardiometabolic renal management as far as diabetes is concerned. And keeping that in mind, we are also aware that each oral hypoglycemic drug which came into being post 2008 had to go through the litmus test known as the cardiovascular outcome trials. And it was only when these drugs came out successfully of these trials that we were allowed to use them in clinical practice. Keeping that in mind, we are well aware that these two wonder molecules, one is empagliflozin and a very closely related dapagliflozin, came out with two very important landmark trials, one known as Declare Timmy and the other known as EMPEREG outcome. So what EMPEREG outcome really demonstrated us, and how this EMPEREG outcome was different from Declare Timmy, is the fact that EMPEREG outcome enrolled more sicker patients, in the sense that all patients in EMPEREG outcome had atherosclerotic cardiovascular disease, proven ASCVD, which was 40% with the Declare TB trial, and 60 had risk factors of ASCVD. So more sicker, more advanced patients were enrolled in EMPEREG outcome, and in all patients were diabetic. Of course, it was entirely a diabetic population study. What it convincingly demonstrated, this EMPEREG landmark, the most important trial paving the way for empagliflozin, showed that it has a significant reduction of 3-point MACE. And by 3-point MACE, we are well aware that what we mean is all-cause mortality, cardiovascular mortality, the ischemic stroke, and non-fatal MI. So these things were marvelously reduced with empagliflozin, and the same was also demonstrated with DAPA. But as I told you, the more sicker patients, so more benefit. And yes, of course, I forgot. I should definitely highlight that EMPEREG also demonstrated a mortality benefit, which was not shown with the Declare. So that is how it paved the way for. And what also came out from these two trials is that there was a reduction in heart failure hospitalization. What was key point to which came out from these trials, from these SGLT, was that they had a profound effect on reduction in heart failure hospitalization. Not that the patient at baseline had heart failure, even then there was a reduction. That actually prompted these, first Professor McMurray, who was the pioneer of DAPA-HF, and then followed by the other principal investigator, might not be remembering his name, of the Emperor Reduced trial. So once these drugs demonstrated convincing cardiovascular benefit in diabetic population, the principal investigators of Emperor reduced and DAPA heart failure went a step ahead, and they actually tested, enrolled non-diabetic patients as well. As we have all understood, or we well know, that in both these landmark trials done in patients with heart failure with reduced ejection fraction, where the EF was less than 40, we have all understood that more than 50% of patients were non-diabetic. So that is what stands out in bold relief with these two agents, that for the first time an oral hypoglycemic agent was exclusively used in a non-diabetic population, both in emperor reduced as well as this DAPA heart failure. So that is how we cardiologists come into the scenario, because regardless of the diabetic status, I would reiterate on that, regardless of the diabetic status, we are all aware that in heart failure with reduced ejection fraction, SGLT is a must, SGLT2. And by SGLT2, I don't mean canagliflozin for that matter. I really mean empagliflozin and dapagliflozin, because you only have trials in non-diabetic population with these two drugs alone, not with all. So certainly it is a class effect, but evidence-based is strongest with EMPA and DAPA. So it goes without doubt that it is a class 1 recommendation as far as heart failure with reduced ejection fraction is concerned for both these drugs. Now, once, one step ahead at a time, first it was demonstrated to be efficient in cardio efficient in diabetic population. Then we went a step forward to test these molecules in heart failure with reduced ejection fraction, even in non-diabetic subsets. And then the last step was that in trying to conquer all bastions, the last step which was left to be conquered was certainly, what about heart failure with preserved ejection fraction? So that was the last bastion which was left to be conquered, and we are all aware that in contrast to the management principles of heart failure with reduced ejection fraction, where we have a number of options to provide to our patient, we don't have you are actually limited for choices in heart failure with preserved ejection fraction. We don't have any definite molecule which can reverse the pathophysiology. What we so long had was diuretics and heart rate lowering agents, but now of late, given these landmark trials, that is emperor preserved and of late the deliver, so both these drugs go hand in hand, I mean the SGLTs. Now they have shown convincing benefit even in heart failure with preserved ejection fraction. Someone who has a EF of from 40 to 60, to the tune of 60, though Emperor preserved showed maximum benefit up to an EF of 55 to 57. Benefit was more in the female population, but certainly it showed this convincing benefit. So across the entire spectrum of cardiovascular disease, and more so in heart failure population, these drugs certainly find a place. It is a class 1 recommendation for reduced ejection fraction and a class 2A recommendation according to the recent ACC guidelines in preserved ejection fraction patients. Now a word or two of linagliptin. So we spoke at length of the SGLTs, but as far as Lina is concerned, it supposedly is the best DPP4 inhibitor that we have at hand. We as cardiologists, specifically as far as I am concerned, yes, there might be some prescriptions where I do prescribe, but the onus lies obviously on my, the endocrinology, my colleagues, to actually initiate these drugs, because these are, specific for the diabetic population. You can't really add linagliptin in a non-diabetic patient as we can with a SGLT2. There lies the basic difference. We are obviously, as for when we try and compare the DPP4, the maximum evidence base is with Lina. You have two landmark trials. One is Carolina trial and one is the Carmelina trial. Carmelina not only demonstrated cardiac safety, but also demonstrated renal safety. We are all aware that the least, renal excretion of all the DPP4s is with Lina, 5% only. Not only that, it can also be used in liver dysfunction. So both end organ damage, even then you can have a drug as safe as linagliptin. It is a once daily dose molecule. So that way it wonderfully complements empagliflozin. No wonder we have a fixed drugs combination with an EMPA and Lina. So that is from my perspective what I wanted to say, and then we can have a discussion. Thank you.